Rachel, you're on mute.
Thanks, Colby. Okay, I'll start again. Is everybody in the session then?
Yes.
Perfect. Great. All right, I'll try again off mute. Welcome everyone to part one of the Momentum Core Group webinar series, Driving Change from the Ground Up, a series of success stories in community-led development. Next slide, please. Okay, before we get started, I have a few quick announcements. First off, please feel free to introduce yourself in the chat. And second, as we proceed, if you have any questions for the panelists, we encourage you to submit them through the Q&A function at the bottom of the screen. As well, you can upvote your questions that interest you. Our panelists will answer questions following each of their presentations. Feel free also to use the regular chat space for any general comments or reflections. Next, please. You can view the slides in either English or French. At the top middle of your screen, you can select View Options. That's just to the right of the green bar, and you'll see two choices, English and French. Next. We are also offering simultaneous interpretation in French. To choose your language, you click on the globe icon at the bottom of your screen. Everyone who's here should select a language to be sure that you hear all of the presenters. Please note that we don't recommend selecting mute original audio, as you will only hear the interpreted language and you might miss out on a panelist speaking. Okay, next, please. Voici les mêmes instructions en français. Lastly, this webinar is being recorded, and we will send out the slides and recordings shortly after the event to everyone who's registered. Next, please. Okay. I think we can go back one slide. Yeah, thank you. So this webinar is co-hosted by Core Group and the USAID-funded Momentum Project, which is a suite of awards working in more than 40 countries to improve the health and well-being of individuals, families, and communities with the goal of accelerating the reduction of maternal, newborn, and child death and disability. Momentum works with USAID partner countries to tackle unique country-specific challenges while ensuring interventions have the best possible impact and reach. Next, please. Core Group unites a coalition of over 236 NGOs, universities, foundations, corporations, and individual experts to end preventable maternal, newborn, and child deaths worldwide. Core Group drives collaborative action and learning to improve and expand community health practices for underserved populations, particularly women and children. Next, please. My name is Rachel Wax. I'm the Senior Director of Programs at Core Group, and I'll be moderating today's event. It's really a pleasure to be with all of you today. Thank you. So our plan for this webinar is to start with 3 short presentations. As each person's presenting, feel free to add any questions in the Q&A tab at the bottom of your screen and any comments and reflections into the chat. Following each presentation, participants will have the opportunity to engage with the experts during a Q&A session. We'll have, after the presentations are finished, we'll have a discussion with the full group so that we can dig in a little bit deeper and reflect on the lessons learned from their work. Next, please. So now I'd like to introduce you to our 3 speakers. Doris Lamunu is the Secretariat Director for the Core Group Partners Project in South Sudan. She brings over 10 years of experience managing public health programs focused on strengthening health systems, reproductive health, capacity building and human resources, improving immunization coverage, and advancing community health outcomes. Previously, Ms. Lamunu held roles with Amref Health Africa and the National Health Training Institute. Her background includes public health, clinical medicine, health education, HIV/AIDS counseling, monitoring and evaluation, and more. She holds a master's and bachelor's degree in public health and is a passionate advocate for community health and building local capacities. We also have Dr. Sadatu Ibrahim Ringim, who is a medical doctor and the immunization advisor for the Momentum Routine Immunization Transformation and Equity Project in Jigawa State, Nigeria. She has over 2 decades, of experience working in immunization, malaria, disease surveillance and notification, and nutrition breastfeeding programs. Dr. Sadatu has worked on projects with USAID, UNICEF, and WHO in the areas of integrated primary health care services, immunization, child health, and polio. Dr. Tobijo Dennis Sokiri Moses is a seasoned public health professional and technical advisor for the Rescue Initiative South Sudan. He holds a PhD in public health and a bachelor's degree in project planning and management. Dr. Moses has contributed significantly to public health research and practice, and he has been involved in multiple USAID-funded and UNICEF-supported research projects focusing on routine family planning data, public health emergencies, and child marriage. He's played a pivotal role in emergency response initiatives and has presented on healthcare protection in conflict zones, as well as COVID-19 vaccination efforts in South Sudan at international forums, including the Boost Community Sabin Vaccine Institute and the International Peace Institute. So with those introductions, I'll turn it over to you, Doris. Next slide, please. Doris, are you there? Are you able to hear us? Or to speak?
Okay, good. Thank you.
Sorry, over to you. Yeah, over to you. You can start. Thanks.
Thank you. I'll just say thanks to Rachel for that wonderful introduction. Thanks, Momentum and Core Group, for organizing this webinar. Let me try to have my video on for a while. And if it's challenging, then we'll put it off and we'll continue without the video. Today, I'll be sharing with you our experience as Core Group South Sudan in terms of building the local capacity to strengthen immunization system and as known the fragile context of South Sudan. Next slide. To start with the context, South Sudan national immunization coverage has greatly improved over the past 5 years. 59% in 2018, and now by 2020, we're already at 72% coverage, at least children receiving DPT, the third dose of TPT. Even with that good coverage, still challenges exist in terms of facilities. Only 26% of the facilities nationwide at least have 2 vaccinators, and only 29% of the health facilities also have trained vaccinators. This has caused a challenge of irregular immunization service delivery in terms of because of the human resource gap and inadequate community outreaches. As all known, not most of our families or communities live near health facilities. Majorities are over 10 kilometers away from the health facility. So the best way to reach them is only through outreach and periodic intensification. So with all those challenges, still there exist a lot of outbreaks. Currently, we are battling outbreaks of yellow fever, measles, vaccine-derived polio. As I speak now, the third round of polio NOPV2 is being administered nationwide, with the last case of CVDP2 reported on the 22nd of October this year. Next slide. For Core Group Partners Project, this is the network that we have built and we have integrated. This is a network that was built for polio program, and now we have integrated to it immunization to really strengthen the immunization service delivery in the communities. We work with over 83 project supervisors. 24 of them are females and 59 are males. We have 166 vaccinators who are supporting over 86 health facilities. These are facilities that are not being supported by any partner, not even by the government, do not have enough human resource in those facilities, and yet there are children in those communities that also deserve immunization. So we have integrated this immunization to our home health promoters. We work with over 1,553 home health promoters, and to this are attached 10,247 community key informants. These are all network in the community meant to support immunization system strengthening. So with this, we are able to derive out the strategies. Let's get to the next slide. So these are the strategies that we employ through this network: the project supervisors, the home health promoters, the vaccinators, and the key informants. First, the home health promoters increase demand by visit to house, and they're able to track immunization issues within the community, discuss with the key community influencers on importance of immunization. They're able to conduct mother-to-mother group meetings to really intensify the discussion on immunization and pull out the importance and the myths that really exist in the community. Tracing of newborns, we still have a number of home deliveries happening to date. So these home health promoters are able to track the immunization system in the community, check the children who are delivered at home at least 0 to 14 days and refer them to the facilities. We have not stopped until that. They also moved to the social places, especially churches, the mosque, the markets, the water points. In South Sudan, we still draw water from a communal source. So you find people queuing for more than 30 minutes to fetch water. So that's enough time for the home health promoter to deliver information on immunization. With this, there are communities that really far, more than even 10 kilometers away from health facilities. They are either in their farmland, they are either from the mobile communities or the agro-pastoralist communities. So we map out these such communities together with the county health department and do a micro plan to identify how many children live in those communities. What are the type of vaccines that we need to deliver so that we also don't take excess or take less for the children. So these are targeted for periodic because of the logistical issues that are attached to it. They are targeted for periodic, for quarterly sessions, and with the aim that at least before a child that starts the first birth dose, do not celebrate the first birthday before completing the immunization schedule as indicated by the South Sudan immunization strategy. We also facilitate outreach facilities, immunization activities, especially by the 166 vaccinators. They do not sit only at the health facilities, but most of the time, at least 4 of the weekdays are in the communities and only 1 day at the health facilities, depending on other primary healthcare services that are being delivered. For example, there could be antenatal clinic or people coming for open OPD days. There are specific days that the facility uptake is quite high, so would encourage that they sit at the facility, but 4 of the days of the week, they're in the communities. These vaccinators are also well-trained according to standard by using the IIP training modules of South Sudan. Key to also mention here is that the joint animal and vaccination in the cattle camp, we have always treated the cattle camp as a hard-to-reach area because of their mobile strategies, not being in a fixed place, looking for pastures for their animals, not interested in the human health issues, but concerned about the animal health issues that they face. So we have several times joined hand with FAO, UN agency, to support and reach the cattle camps. So as they move in with their vaccines for animals, we also move in with the vaccines for human beings. So this has proved to be a very good strategy in the cattle camps, and we intend to escalate further. Male engagement, especially during the commemoration of African Vaccination Week and Polio Days, because decisions in the household for a child to get vaccine is also relying mainly in the hands of the father, of the parents, of the fathers. So even when we deliver the information to the mothers, still the fathers need to get engaged and then give the decision to accept for vaccine to be administered to their children. Next slide. Overall, in FY 2024, because we look at only the remote places, currently CGPP operates in about 39 counties of South Sudan. And all these 39 counties are in the most remote part of the country and in the border communities. We border Sudan, border Ethiopia, border Kenya, Uganda, and Congo. So those are the border counties that we serve, and we still within the border counties, we do not offer immunization at the town level because in the town there are a number of health partners or the county health department is well strategized. So we move down to really remote areas, the Payams, the Bomas, where health facilities are not in existence. So in the year 2024, this has been our achievement to date in terms of strategies. From my dashboard, I see it as hot pink, which is the total number. If you look at OPV0, in total, we are able to achieve up to 14,000. OPV3 up to over 23,000 with the both strategies of fixed and outreach and PIRI. Penta 3 is over 30,000 and measles is over 26,000. Again, as the target, if we analyze this, we realize OPV0 is 40% achieved, again as the target, and achieving OPV0 40% target is also a great achievement because currently with the home-to-home visit that the home health promoters are doing, we have started seeing a turn-up of more health facility deliveries. There are less home deliveries being conducted now with the awareness that is being given. So at least mothers end up delivering in the health facilities and children are able to take the first birth dose right from the facilities. So the 40% are really still some few pockets that we end up getting in the communities. 90% achievement for OPV3. And if you look at OPV3, Penta 3, and measles, this is basically because of defaulters. Much as they have got the first birth dose in the health facilities, going back to get the second dose, the third dose, now it deteriorates, it reduces. So only through defaulter tracking that we are able to achieve this. Next slide. We do also risk communication and community engagement to really create demand, generate demand in the communities. So the home health promoters are able to move house to house. So we have a number of sessions. We do the house to house, which is for one-to-one contact, visit to social places for a public engagement, and then mother-to-mother group discussions. So that has been the achievement to date. In terms of defaulter tracking, we have also realized that especially defaulters for routine immunizations, only 74% of the numbers that were traced were able to report back to receive their vaccination. Among the newborns, only 81% were able to report and receive their vaccine of first birth. And the same to women of childbearing age, only 67% were also able to receive. So this still goes back to the challenges, the myth, sometimes the distance from the facilities that they have to undergo to reach and get the immunization. Next slide, please. So these are some of the challenges that we face in those remote areas. Insecurity and access issues still remain key because of the fragility of the context. So what we do as core group is to continue negotiating with the conflict parties that we are only bringing health services and health services alone. So this takes quite a while, the interaction and building the trust for them to ensure that the health workers are able to access the community under those conflict areas. Access to difficulties, reaching remote areas, especially mobile communities. It's quite, especially along the borders. These are communities that are always across, they move, it doesn't take a while that they are move across the other country in search of greener pastures and the rest, or difficulties within the environment where they live, or having relatives across. So for many various reasons, they're always not there. If you look at this picture, this is one of the last mile delivery process. So even a speedboat cannot connect, a canoe cannot connect. It's only such an innovation that can take a vaccine to that one child or 10 children that are missed out through the normal routine immunization or the regular routine immunization program. Social-cultural barriers, vaccine hesitance, we still get this a lot, especially during advocacy meetings. It's very clear when issues of that if my child is vaccinated, the child might end up infertile, in future will not give birth, or the child will, after some years of growth, will develop illnesses that will never be treated. So all these informations keep coming out and it really hinders the children from getting vaccinated. So what we do here is to really continue working with the local communities, first understand their context, understand their beliefs through the focus group discussion that we conduct, and then we engage the community influencers like the chiefs, the traditional healers, who are already part of the key community informants to really dispel the myths in the community. Resource constraints remain key because these resources will always not be enough, especially in the hard to reach areas, very difficult terrain, even vehicles, just example in this case. So such a person does not have a price for the innovation he gives, will just ask you any amount of money. But because you want to get there, even getting a receipt for such a process sometimes become complicated because all he knows is he's doing an innovation and is trying to help you reach your services. Next slide.
Doris, we're nearing time, so if you could maybe quickly discuss the lessons learned, and we'll proceed to a question.
That's my last slide. Thank you very much.
Thank you.
In terms of lesson learned, this is what we have learned, that really using a community-based structure for offering services is a bigger asset to the community. It really builds trust, it brings in the participation and contributes to the success of public health issues. Above all, it really brings a lot of collaboration, adaptation, and community engagement. So using such as structures for immunization has been our lesson learned and has been our achievement and our success for FY 2025. Next slide. Thank you very much. First, our vaccinator and the project supervisor after a scheduled program, a scheduled outreach. Now it rained, and that is the only road available, but they were able to continue to move and reach that one child with vaccination. Thank you, Rachel. Over to you.
Thank you so much, Doris, for that presentation. Sorry to rush you a little bit there. We have a question from the chat. Somebody's interested. You mentioned a lot about the community vaccination and the community participants who are part of this, the vaccination campaigns. They're wondering if the home health promoters are paid or compensated for their work and engagement with this program.
Thank you very much. The home health promoters are incentivized. They work 4 hours of the day into the program and they are paid. In a week, we expect them to reach at least 9 households and meet at least 5 community key informants to be able to track out what information they have received within the week. The community key informants, we do not pay them. These are influencers of the communities because of the nature of work, the nature of interaction with the community. They are always in touch with the community. So this could be especially primary teachers, primary school teachers. There could be people selling, having their small dispensers within drug shop, within the community, traditional birth attendants, traditional healers. For example, I can give you one example of a case that was a contact that was traced from Gambela and spilled out to South Sudan, came to Nasir to meet a traditional healer. So it happened that this is our own traditional healer that was able to manage. So even when he was doing his traditional healing processes, was able to refer this case to the home health promoter. So we do not pay them, but at least we have contacts on a quarterly basis. We have contact, we have meeting sessions with them. We call it a mentorship session, that at least within that we are able to motivate them and then encourage them on really the community diagnosis of each of those cases that we are tracking. Over to you. Thank you.
Great. Thank you very much, Doris, for the answer to that question. If we, during the panel discussion, if we have enough time, we'll be able to take more questions. So thanks again. Why don't I turn now to Dr. Sadatu for her presentation.
Thank you very much, Rachel. Good morning, good afternoon, participants, and it is a great pleasure for me to share with you today work done in Nigeria, Jigawa State, precisely relating to creating sustainable solutions for engaging communities and building community-level capacity. Jigawa State is one of the states in the northern part of Nigeria, and this work is done by Global Momentum itself and the Nigeria team, as well as the state government participating in it, and specifically the Result for Development core group member of the MRIT. Next slide. So by way of background, Momentum Routine Immunization Transformation and Equity, MRIT, the project in Nigeria aligns with priorities of the Jigawa State Ministry of Health and shares a commitment to improve immunization coverage and equitable access to healthcare services. So for this particular intervention, the challenge was that LGA health staff lack some basic essential skills, awareness of budget cycle and processes, and confidence to effectively communicate financial needs to routine immunization local actors involved in resource allocation. And so our intervention spanned in the period between June 2023 and August 2024 so far. The project aimed to train and support district health and EPI officers to engage local finance officers and other officials to advocate and increase funding for operational costs for reaching zero-dose communities and children with potent vaccines through routine immunization program. Next slide, please. So what is our approach? We conducted a health financing landscape and mapping of the key stakeholders to abreast us with the key issues relating to resource mobilization and funding for routine immunization, after which there was a co-creation and implementation, planning for implementation of some capacity buildings to address the gaps identified during the landscaping. This planning was done with the State Ministry of Health, the State Primary Healthcare Development Agency, Ministry of Budget, and the Ministry for Local Government. The focus for the intervention was in 2 of the 27 local government areas of Jigawa State, namely Dutse and Kiawa, and were 3 series of workshops carried out between March and August 2024. The first was on data analysis and reporting, and also situational analysis. The second was on budget preparation and fund request memo development, and the third one was on effective advocacy, in which there was practical session of conducting an advocacy to key stakeholders. Next, I will take us through a little more details relating to the workshops that were conducted. The first one on data analysis and situational analysis, the objective for that workshop was to equip the participant with skills and knowledge on how to leverage data analysis in support of domestic resource mobilization for routine immunization. The participants were key stakeholders or program officers at the local government level in these 2 local government areas, alongside some of the administrative teams of the local government area. Next. So next slide. Next slide. Hello, next slide.
I think, Dr. Sadatu, I think it's advanced. for the webinar. Which slide would you like to show? Is it the outcomes of workshop 1?
Yeah, the outcomes of workshop 1. Are we there? I don't see the slides moving.
Yeah, we're there. I can see that slide. I think others can also.
Okay, we are outcome of workshop 2. So can you move back to outcome of workshop 1 so that I take it from there? Yeah, the slides have moved now. Can you take us back slightly on the outcome of workshop 1? If we are there, I can talk from here, but I'm still on outcome of workshop 2. Are we there?
It should be
Yes,
coming.
we're
I
there.
think there's a slight delay.
Okay, I'm still seeing outcome of, I'm seeing workshop. Yeah, thank you very much. We are there. So the outcome of the first workshop, which was on data analysis, was that there was increased knowledge and proficiency of the participants involved in routine immunization program about immunization funding, and there was substantial improvement in test scores. Participants, the knowledge gained based on the pre and post-test scoring was about 57%. And this workshop basically took participants through the DHIS2 and how they can get data, analyze it, look at the indicators for routine immunization, identify what the gaps may be from programming, and then begin to look at what are the funds required to address the gaps. Next. Are we on the next workshop 2?
Yes, it has changed.
Okay, if we're there, I don't seem to see it, but I can speak to the slides. That workshop was on budget preparation and fund request memo development, which was the main highlight of the entire intervention. And the objective of it was to provide a comprehensive understanding of the Jigawa State budget cycle, processes, and templates, and give the participants practical experience in drafting a budget for routine immunization and drafting a fund request memo. So can we go to the outcome of workshop 2? The participants still were majorly the technical team for routine immunization activity and programming at the local government area. If we are on the outcome, that workshop was able to provide an understanding of budget cycle steps, regulatory and policy framework, key stakeholders that are involved and need to be engaged with, and their roles. And then it also provided the participants an opportunity to have hands-on creating their own draft budgets for routine immunization for these 2 LGAs that were part of the workshop, and then also drafting a fund request memo template. Next slide. Just to talk about the third workshop, yes, which was on effective advocacy and meeting with key stakeholders, including the chairman of the local government area and key persons at the state level. So the participants were successfully taken through smart advocacy, and from the practices of what they had been doing, were able to really know what it takes to advocate for funding and who are the even stakeholders that they need to engage with for resource mobilization. Next. So the outcome of the third workshop, which is on advocacy, was that both the 2 LGAs have included for the first time, budgets of up to 20 million, approximately $12,000 for routine immunization in their 2025 fiscal year support for activities for routine immunization. Basically, in terms of capacity building for the health ambassadors who are domiciled in the community and engaging with community to promote RI programming, also in advocacy efforts through the leaders, community leaders, both the traditional and religious leaders, in addressing issues relating to zero-dose children and under-immunized children, and also providing logistics support. An unintended outcome was also achieved in this intervention, whereby the State Ministry for Local Government Affairs directed all the local government areas in the state to include 20 million budget for routine immunization. So by mobilizing local budget for community engagement activities, we maximize the sustainability by local actors and local sources of fund for routine immunization. Next slide. Yes, so I have said that the key achievement was driving fiscal ownership, getting the government to put more of its money into routine immunization, considering that Gavi and other partners have been greatly and heavily supporting routine immunization. So as part of the next steps, we intend to organize a virtual meeting with primary healthcare managers of the remaining 25 local government areas to share the experiences from the 2 LGAs on routine immunization planning, along with budget templates and planning tools in collaboration with the Jigawa State Ministry of Health, Ministry of Budget, and Ministry of Local Government. We also intend to have budget performance and monitoring toolkits to monitor performance in 2025 and also address whatever issues may arise. And then we also intend to schedule a follow-up advocacy meeting with the newly elected local government chairmen from Dutse and Kiawa to secure their commitment to prioritize routine immunization in 2025 fiscal year. What happened is during the course of the intervention, there was election and change in leadership of the local government chairman. So this next step activity is very critical to carry along the leadership of the local government to ensure that the commitment is achieved and the sustained support. We also intend to monitor the budget flow with the new autonomy. What also happened in the course of intervention is that the government of Nigeria has separated the state and local government joint account, whereby local government now have autonomy and will be budgeting and implementing their activities. So there is need for continuous and sustained advocacy. Then we want to also continue to document the processes and results and share more lessons relating to this intervention. Next, last slide is to say thank you very much.
Great. Thank you so much, Dr. Sadatu, for that interesting and really informative presentation. We are, in the interest of time, we are going to hold on to our questions until the panel discussion. And so we'll proceed right now to Dr. Tobijo to have your presentation, please.
Thank you so much for giving me the opportunity. I hope I can be heard loud and clear. Next slide. Yeah, so we are a national non-governmental organization that had been in existence for the last 10 years, having been founded in 2014. And we have a focus on emergency development. At the moment, we are present in 6 states. And important to this is that 4 of these states are under US investments, including Western Equatoria, Lakes, Central Equatoria, and Eastern Equatoria State. Next slide. Next slide, please. Okay, so we joined the Momentum Integrated health resilience in April 2022 on a sub-award agreement modality. Basically, with the project focus on organizational and technical performance, grants management, capacity strengthening, and family planning, routine, reproductive health, maternal, neonatal, and child health community programming. Under these sub-award arrangements, the annual budget gradually increased from the initial award up to where we are now in fiscal year 3. Next. Okay, I don't see the slide moving, but yeah, so okay, fine, thank you. The technical and organizational capacity strengthening part of it had clear objectives, and one of these objectives was to have the organizational capacity of our organization strengthened, and then we had to implement the family planning, maternal and neonatal health activities as per the model we use, what they call the partnership defined quality, then grants development capacity to apply, manage, and account for direct donor funding, especially from USAID, and then of course ensuring that we had that opportunity to strengthen our relational capacity. So what were the processes? Next slide, please. Build on these clear objectives came in very clear processes. For example, we had the comprehensive engagement with the Momentum Integrated Health Resilience, especially developing purposes and goals for capacity strengthening. We had a comprehensive facilitated self-assessment undertaken to identify capacity gaps, including the local integrated capacity assessment tool, the organizational performance index, and other tools such as the perform tools. We were able to jointly identify and analyze the gaps and implemented a capacity strengthening plan to address these gaps. We benefited from proper support, both through mentorship, training, technical assistance, and on-site, including coaching. We documented all these lessons learned through the capacity strengthening processes and had annual reassessment to measure changes in the organizational and technical capacity. Next. So the next is simply the display showing the processes, how it all started. First of all, with the joint capacity assessment, then the development of the capacity strengthening plan, implementing it, documenting and learning, and then doing the reassessment, and then continue with engagements and consultations. So all these were the processes with these clear objectives to ensure that there's continuous technical assistance support, and then there is continuous planning and implementation of efficiency and quality improvements. In doing all this with all the focus of ensuring that we are able to come out as a strong organization. Next. So with all these, there were very clear results or outputs, and they basically through the support of the technical team from MIHR, we had a number of documents that were reviewed and that were otherwise developed. We were able to streamline and institutionalize various practices that improved our effectiveness, including enhanced skills, knowledge of staffing. We improved from the scores overall, averaging from 1.8 at the beginning to 2.9 in the 3 years. And we both, that is in the organizational capacity, similar to the technical capacity also had that increment. And interestingly, we were able to bid successfully for a direct grant and qualified to receive direct funding from USAID PEFA of 2 million. This is a grant called the community-led monitoring activity. I know it's not part of this, but in addition to this, I am proud to say that through the support of MIHR, recent audit reports showed strong financial capacity, and including 2 recent and modified audit opinions. Next. So the next slide is just a visualization of these results, and I know it's somehow crowded, but I would just say that under organizational capacity, you would see that there is a strong indication of growth in strategy and planning, financial management, external relations, resource mobilization, and sustainability. Next slide. Under technical assistance, in the next slide, of course, our focus is family planning. You will also see that there are improvements, significant improvements in family planning, maternal newborn health, nutrition, infection prevention and control, youth, gender-based violence. And the next slide is just an indication of how we have progressed from the first year, from a score of 2.7 to 3 to 3.5. Now, the next slide is demonstrating how we have utilized all these capacities that we have gained through this to move it to the local communities. That's what we call the local communities strengthening. One thing that is being neglected, especially when it comes to the debates along localization, is the fact that when people talk about localization, they tend to think it's only about the organization and that. But if we have to have a sustained impact on local capacity development, we must engage the grassroots. So what do we know about the community? First of all, it is evident that the communities, they know the local context, they know the culture, they have the local stories, they have the resource, they have the mobilization capacity, they have existing groups, like women, youth, and religious groups. They have already existing leadership structures. In South Sudan, we have the Quarter Council, the Payam, the Boma, the chiefs, and you can see already from the picture itself, this is a kind of a community that is showing a mix of already all these existing capacities. Next. Nonetheless, despite the fact that we are aware of the existing capacities of communities, we also know the challenges. So what we say that the key gaps in the community is that while they have all the wealth of this information, they lack recognition. They lack recognition, and then they lack the resources. So if you look at the picture we have there, this is us giving a feedback to the community in one of the Quarter Council offices. And these are some of the things they tell us. The truth is that, yes, they know their communities very well, but nobody notices their capacity. Next. So what have we done, and how do we engage them? We made sure that we did what we call the local capacity mapping. We did cultural profiling. We trained the communities. And then the next slide is that we worked with them through the partnership, defined the quality model, ensuring that there is social accountability, there is social advocacy, and engaging them in various social, what we call social strategies, including community dialogues, radio listenings, sports, dramas, mail board games, success stories, role plays, and many others. So this, in our own mind, this is one way we utilized to ensure that we had accountability for the resources that we received from MIHR. I know we are going to the last slide, but before we go to the last slide, I just want to make a quick summary on what we have just said. First of all, on strengthening the capacity, at the side of momentum, I saw clear strengths that if you have to achieve this, there must be clear objectives. There should be a logical process. You must use the right tools, but also start early with the partner and have a leadership that is willing to push this further. At the partner side, leadership is also key. There's need to have the right team. There's need to have the right environment. Ensure that you engage the communities, because this is then when the staff can see results, and that accounts, that contributes into motivation. Thank you so much for listening.
Thank you very much, Dr. Tobijo, for that presentation. And as we have mentioned, we will now proceed to the panel discussion. We have three very different interventions and three that we're going to look at and discuss. I'd ask for all of the panelists, if you could please turn on your videos if your network allows. And I will start a series of questions. I would just request that you try to keep your answers a little bit brief. Thank you. So Dr. Tobijo, why don't I start by asking you a couple of questions based on your presentation. And I'll ask both of them, and then you can respond to both of them together. So the first thing that I'm curious about is, as you talk about capacity strengthening, can you discuss a little bit how that's changed the way that you manage and implement the projects that you have? That's the first question. And then secondly, as we all know, organizational change can be difficult. And could you talk a little bit about any kinds of resistance that you may have faced from the staff of the organization, and how you prepared the staff for this process? Thank you.
Thank you so much for that interesting question. What every organization strives to have is to have effective and efficient system. Now, all these various capacity strengthening efforts that we got through our collaboration with Momentum had dimensions of strengthening our systems. For example, financially, we made sure that we had a better, well-functioning financial management systems. We had good program management systems. So all these were meant to ensure that we were both effective and efficient in doing our programs. And then coming to the second question on resistance, yes, there is no way that a change can happen without resistance. Particularly what we see is, from what I have observed in the organization, is that some staff felt that the tools that were utilized to derive this change were so heavy, and so otherwise would sometimes not be available to participate. But we managed to ensure that before even engaging any other person, any staff, you have to explain, you have to be very articulative. You make sure that at least every part of the organization, all the staff are involved. And that is how we overcame resistance. Thank you.
Great, thank you very much. Why don't I proceed to Dr. Sedatu? Could you talk a little bit, Dr. Sedatu, about the biggest challenge you faced during the workshops, your budgeting and funding workshops? And also, as you mentioned, one of the results and one of the unexpected results was that the 20 million Naira that's now included in each LGA, you had only worked with 2 LGAs, but the unexpected result is that that was extended to all of the LGAs in Jigawa State. Could you talk about a little bit, did the participants have any desire to expand this type of budgeting to other health areas and other needs that they see within their LGA? Thank you.
Thank you very much for the questions. They are really very insightful. Really, with regards to the workshops, the capacity building workshops, we didn't have much challenge because these workshops were informed by the landscape analysis to find out what are the needs to augment the health team to come up with what is required for them to mobilize resources for routine immunization for the program. So there wasn't really much problem. It's just that at the tail end, when we were to demonstrate advocacy to the local government chairman, there was a transition to sole administrators, so we weren't really able to get the local government chairman for the team to really practice relating with the heads of the local governments. And that was actually done with the sole administrators, and that is why it is in our next steps to key in with support to the LGA team to meet the local government chairman. In terms of the support you said for the other LGAs, that is why we are thinking of a virtual engagement of all the LGAs to allow DUSE and Kiawa LGA teams to share their experience on the processes. And also we are planning to develop a budget performance and monitoring toolkit to monitor the performance of budget activities in 2025 budget fiscal year by the LGA team. Thank you. I hope this provides some response to what you asked. Thank you.
Great. Thank you very much. And very quickly, I'd like to ask you, Doris, a couple of questions. One thing you mentioned is that some of the challenges you face is within the community is vaccine hesitancy and cultural beliefs related to the vaccines. I'm wondering how you, if some of the home health promoters had these same types of concerns and hesitancies and how you addressed this with them. And a little bit on a similar vein, how you addressed male engagement and how you were able to increase male engagement in vaccination and male support for vaccination. Thank you.
Thank you, Rachel, once again for the question. Yes, vaccine hesitancy still exists in the communities. Maybe one thing to elaborate is how do we draw the home health promoters that we get on board and which communities do they come from? One of the challenges even the communities have raised is that they do not want vaccinators from another community to come to vaccinate their children. So those are all strategies that has helped in our community strategies. So the home health promoters are recruited directly. They're actually selected or seconded by the chief, the community leaders. We get a good number of them following the criteria that we have set for the community leaders. And then again, we engage them into a selection criteria. When they meet the standard for what we want to deploy them to do, then we train them. So this hesitancy comes right away from, even from the time we engage the home health promoters, we get to see what the community already say about vaccines. So during their training, these are spelled out. The myths and then the beliefs are spelled out during the training. So the community, the home health promoters are themselves engaged. They understand that this is what comes from their communities. This is the belief that they have about the vaccine. But during the training, that has been transformed. And that's why they're able to go back to their same community and discuss about the importance of immunization. And we see this uptake. So in terms of the vaccine the male engagement, yes, we have day to day, because it's really quite difficult to get the male as easy as you get the mothers in the house. Most time they're either seated in their other different areas or they're already taking care of the kettles or they're busy in their workplace. So the best moment that has always worked for us, especially during the commemoration times, when we're commemorating the African Vaccination Week, the World Polio Day, advocacy discussions are really tend to draw the attention of the males in the discussion, in dispelling the myth. So this is how we're able to bring out the male engagement into the process. If you see, one of the pictures in the presentation was during World Polio Day, where it was the man that collected his children. He actually came with 3 of his kids himself without the mother to come and get to give vaccine to the children. And that we have taken his consent. Time to time, we use his pictures to say, even men can do this. Not only the role of a woman alone to carry the children for vaccination. A number of men have always told us that we even do not know the schedule. We do not know how many vaccines these children should have. So why should you tell us that we should carry it? Let the mother take. I will tell them, fine, come, check the vaccination card and see the schedule, what is next. Because at least for you as a man, you're able to read, but even the woman cannot read. So those are some of the one-to-one interaction that we have used to really engage the men to support immunization in their community. Thank you, Rachel.
Great. And thank you so much, Doris. I also just want to, we're at time, but I want to really say thank you to all 3 of the presenters. I think it was really wonderful to hear all of your presentations. Thank you again. Also, thank you to the participants for taking time to be here today. Just a quick reminder that we will be sending out the slides and the recording to everyone, and also that this is the first of a 3-part series. So you will be hearing about the next 2 sessions in this series. Thank you again. And please do complete this survey. Thank you very much.